vegetation made of? It's kind of a combination of blood clotting, so it kind of clots together. There's some red blood cells and stuff involved with that naturally, but it's an infective process typically, so it is typically either a bacteria or a fungus that does that. A virus doesn't necessarily give us um, build up like that because viruses are much smaller. Having said that, if we have viral infections, sometimes like so back in the day when we were kids, you would have an infection that would last a long time, and if it was a viral infection, what was usually the treatment for a viral infection? So say you got the common cold. Okay.
Rest.
Yep. So there's a saying that if you got a common cold, it's either 7 days or a week. In other words, same thing. So you really got to wait it out. When I worked in the pharmacy, the pharmacist always recommended somebody had cold and sore throat because of the virus, and they had a low grade temperature because typically a typical virus is a low grade temperature, meaning that it's above the 98.6 Celsius, but less than 104. You start to get over about 104, then it's more likely to be a bacterial infection. So those significantly hot fevers are typically bacterial. Could be fungus as well. So those ones, so you would have to typically wait it out. So there wasn't really any medication or anything other than just alleviating the symptoms. So it was lots of water and Tylenol for headaches and stuff like that for a viral infection. But rule of thumb is if it's about 7 days is what a common cold would last. So if it lasted for the 7 days and I still had symptoms or the symptoms got worse, we would often have like an opportunistic type of a bacteria that would take over and create another infection essentially. So you know that nowadays we have a big issue with drug resistant strains of bacteria and viruses and different things now, bacteria primarily. The problem is that we used to medicate, or there are some doctors that would medicate patients with bacterial type of antibiotics. Regular antibiotics don't work on viruses at all. So giving them a Z-Pack, for example, was to alleviate symptoms. And often they did that just because the patient wanted to have something to help them feel better. In reality, it didn't actually do anything. And because of that exposure to the antibiotics, then we develop more drug-resistant strains of bacteria, which are harder to kill. And so that when you get those types of infections now, it's much more expensive medications to deal with it, or there's nothing available to address it. And so using a pragmatic approach to what we use on treatment is important. And that's why we've ended up in the situation we've ended up in this society now, that we have a lot of drug resistant strains because it's overuse and misuse of the medication. But for a virus, there really isn't a medication to treat or to stop the virus itself. We simply have medications to treat symptoms of the virus. So it's really to alleviate symptomatic stuff. Looks like my clicker finally died on me, so I'm going to have to do this manually. So yes, it's an infective process, meaning that it's typically going to be a bacteria or fungus. Now we have talked a little bit about COVID, since this is a very current thing. And COVID can affect the heart in various ways, including creating and causing myocarditis, lower ejection fraction because of that, etc. Okay. And I've actually, ironically, in the last couple of weeks, I've actually heard a lot of little news clip things about infective endocarditis from a cardiac standpoint from COVID. And actually the vaccine itself, I believe, can potentially cause it. So remember, in a vaccine, when we're creating these proteins and things that come out of whether it's developed by the vaccine providing it or the virus itself providing it, our immune system is reacting to that, and you do get some inflammation type of process systemically that causes these types of issues. So whether it's a vaccine or the virus itself, it has a similar effect on your body. Ideally, it's just not supposed to be on a vaccine. It's not supposed to be contagious to other people. It's kind of supposed to give you a mild grade immune response as compared to a full-blown event. So, so with the heart specifically, so infective endocarditis is localized anywhere on the endocardial surface. So let me ask you this: where does the endocardial surface reside? Where is it?
Isn't
Near
it
the
the whole
blood
inside of the heart?
interface.
Okay, Hillary first, and then Nancy.
Sorry, wasn't it the whole inside of the heart that it runs on?
Yep. Did you have any other answer, Nancy?
It was
No,
me.
it's
I was just saying.
Kelsey. And I love
Oh.
the way she said it, the blood interface.
Yes, that's true. And Kelsey, did you have a comment too?
That was what I said. Nancy was just repeating it for me.
I figured that was true. And yes, it's all the inside of the heart, including the valves. So the layer that goes on top of the valves, valves are very, very thin. In fact, as we've talked about before with echocardiogram, particularly with harmonics on, the valves actually look thicker than they really truly are. So when we see thickened valves, we do get some other stuff going on pathologically, but on a normal valve, they are actually very thin. They're almost a see-through, semi-transparent. They're so thin. And so there's an endocardial surface on both sides of the valves as well. And I talk about the valves because when we have infective endocarditis, that's the surface that is most likely to have vegetation attachment and problems with, but it could be technically anywhere. When we talked about prosthetic valves and prosthetic devices, we can have vegetations form on those. It's not going to necessarily form at the same place on the tips of the valve leaflets like it would on a native valve. It's more going to be around the base of that sewing ring. Okay, so the vast majority in echo that we're going to deal with is on the valve leaflets. Again, these are caused by an overgrowth of basically bacteria or fungus, and it is combined with blood cells and things like that that kind of become part of that grouping. So it's initiating, usually requires a presence of a high velocity jet. Okay, so we have kind of so what we're looking at on any infection. So when we get, let's talk COVID for a second, because that's current. Where does COVID affect you? Where does it find its way into your body? Okay, the eyes primarily, and the nasopharynx area. So in the nose and in the pharynx, those are the soft tissue, the mucosal layers. But the eyeballs are definitely a big part of that also. That's where it seeds. So just like we're seeding and planting a field of for a crop, we would put seeds in a certain area. We expect that stuff to grow from that point. What happens if you over several years after you plant a blackberry bush? For those that are familiar with blackberries, they spread. They go everywhere, right? They're hard to get rid of. And it's not to say that these are hard to get rid of, but the point is we seed it into an area and it can spread from that point, okay? So any infectious type of process, again, it proliferates, it grows. Just one of these stupid random facts that I have in my head. I remember talking about E. coli bacteria, which is in the colon. Its population of cells doubles every 2 hours. Okay, so to give you an idea, these things can grow pretty fast. So if I've got 100 individual cells, then in 2 hours now I've got 200, then I've got 400 in another 2 hours. So it proliferates very quickly. So we need an area to seed the infection. So the reason that the high velocity jets are a way to seed itself is, what do you think a high velocity jet does to the tissue, and particularly the valves?
Inflammation, or are we talking about stenosis?
Okay.
It's like the kid walking down a fence and dragging a stick. It scratches it.
Right. So we're irritating the surface at a minimum. So there might be some inflammation going on there. At the least, it kind of weakens it. And we know that a high velocity jet carries with it a lot of turbulence as well. And so all that kind of stuff, kind of like Nancy says, scratching the fence, we're creating a spot for it to kind of seed itself. So that's kind of the areas that it likes to find. Other normal areas, if it's pretty normal, it usually doesn't attach, although it's not impossible to do that. So a nidus of infection attracts platelets and fibrin, and that collectively with the bacteria or fungus creates what we call the vegetation. And a nice descriptive picture with nice green gunk on our valve. Okay, so as many as 50% of cases do not have lesions associated with high velocity jets. So while they're saying that there's quite a few of them that do, basically half of them don't have to have a high velocity jet. So just because it doesn't have a jet doesn't let us rule that out, okay? And just from a 2D perspective, since we'll talk about this again, but from a 2D perspective, if you see something hanging on the valve that's kind of a hypoechoic to isoechoic, can you diagnose a vegetation just on that alone, or are there other things that can look like that?
You can't.
Okay. Yeah, so there's other things that look like it. What other types of things do you think might look like that in 2D?
Thrombus.
Okay, thrombus for sure. Anything else? We haven't got to the chapter yet.
Tumors and masses.
Tumors and masses. Yep. So anything that's mass-like can look similar. So we see the structure. What do we do with any structure that we see that doesn't belong there? What should we do with it to document it? Any structure.
Describe the appearance.
Yep. So describe the appearance, take pictures of it, see the borders of it, the size of it, and extent of it. So we're going to measure it typically in 3 planes. And you're going to describe its characteristics. Is it mobile? Is it kind of attached to the walls? Is it echogenic? Is it hyperechoic, hypoechoic? Is it homogeneous, meaning smooth and consistent all the way through it? Or is it heterogeneous that has maybe calcifications in it, some bright spots, some dark spots? Those are the ways that we're going to describe these types of things. Mobile things in the heart are typically a little bit more dangerous because they can break off and embolize, causing strokes or other things to occur. So we want to be cautious and cognitive of those things. So the point is when we see these masses, we can't just jump to the conclusion that it is a vegetation. We will suggest that it's likely it is a vegetation, and that will go in conjunction with our clinical history. Early studies relied heavily on the presence of positive blood cultures in association with the clinical evidence. So that means that they did blood tests to prove that it was actually a pathogen that was in the body causing these things, whether it was bacteria or fungus. They would culture those and they would test it. In addition to the clinical evidence, which means that the patient would have had high fever, either currently or recently. Perhaps they've been to a different country where they're more susceptible, things like that. So those types of things would suggest that it's a vegetation. In addition to the fact that we're seeing this 2D structure that looks and suggests that it's in the location of a vegetation. But we have to have that clinical and lab documentation along with the echo to prove that it actually is. Okay, so echo characteristics of the vegetation. So we're looking for evidence of acute ongoing affection. It's not affection, infection. So again, that clinical history, when you take that, is very important. So when you're asking your patients, they come in, first of all, we want to know why they're there for an echo. So you ask them, what brings, you'll have your clinical indication on your documentation and your paperwork that says, we suspect this or do this. They have evidence of this or that. And we're scanning, but you're also asking your patients. So, I'm not going to rely totally on what the clinical documentation says, because again, sometimes that's input by people that are not the doctors themselves, and sometimes they just put stuff in they think will get an echo paid for, and it's not necessarily appropriate. So we confirm those things with the patient. So I always ask my patient, so what brings you in? Why do why do you believe you're here? And they'll kind of tell you. So it's like, well, I've been feeling really, short of breath and this and that. And, maybe here they would say, I was really sick, or I am really sick, and the doctor wanted to check my heart. They don't always know why they're there themselves. And if they didn't say that to me, I would ask them if they've had any recent fevers or infections. Now, if I didn't ask that in my regular clinical history, excuse me, and I was doing my echo and I saw one of these, I am absolutely going to ask them if they've had any recent infections or fevers or anything like that, or if they've been to any other countries recently. And because that would give us some clinical based evidence that something may be happening. Okay, that is important. Okay, so the vegetation is the most common and direct evidence of infective endocarditis. So it is the one thing that we can visually see. Otherwise, they have to do it based off blood tests and stuff like that, which they may not have even done. It starts as a microscopic focus. So again, when it seeds into it, we could have 100,000, we could have 100,000 bacterial cells that are kind of grouped into there. What's the likelihood that you would see that with the naked eye, let alone echo? Okay. It's very small. I mean, these are very, very, very small organisms, microorganisms. They're typically smaller than your typical cell in your body. So we can have a whole bunch of them, and we may not see it. So it starts as a microscopic focus. Some infectious agents they require a smaller dose of them or a smaller number of them to actually begin an infection. So some of them can be as low as like 10 individual bacterial cells. Others might require like, I don't know, we'll say 100,000, for example. So it all kind of depends on the microbe. So typically develops into irregularly shaped, highly mobile mass that's attached usually to the free edge of a valve leaflet. And it's typically, as we've talked about before, on the upstream side of the valve. So again, just to reiterate what upstream is, so if I'm talking about a pulmonary artery and pulmonary valve, which side is upstream to the pulmonary valve? Which chamber is upstream to the pulmonary valve?
Right ventricle.
Right ventricle, good. Good. So you think about the upstream as where the flow came from and where it's going. So that is fairly classic of vegetation. So it's a highly mobile, so it moves quite a bit. It's on that free edge of the valve tips typically, and it's typically on the upstream side. Those are like the main characteristics of it. And the motion of that is usually independent of the valve itself. So for example, if the valve is coming to close, that doesn't necessarily go with it. So the reason it suggests that is because in artifacts, sometimes we get these reverberation type of artifacts that basically do what the structure that's causing it does. So if we had a reverberation, for example, off the valve, we would expect a similar shape that would be moving in the same direction, even though it's reflecting into the chamber beyond it. This is going to kind of move independent of that. It's going to do its own thing. Okay, so echo criteria for defining a vegetation. So positive features, low reflectance. It's attached to the valve on the upstream side, as we just said. Irregular shape or amorphous. It's mobile or oscillating. And it's associated with tissue changes, and there's usually valvular regurgitation with it. Negative findings, just because it's highly echogenic doesn't mean, or a higher echogenicity typically means that it's a more chronic type of a process. These are typically acute and recent, so they are typically a low level echo, like a hypoechoic to isoechoic to the tissue, not usually brighter than the tissue. A non-valvular location, so if we're seeing something somewhere else, it doesn't mean it's not a vegetation, but it's more likely to be something else. Smooth surface or fibrillar, non-mobile, and absence of regurgitation. So those negative findings, again, it doesn't say it's absolutely not a vegetation, but it's a lot less likely compared to other things like masses and tumors and thrombus. Okay, so because of occurrence in high velocity jet, they are often oscillating and or fluttering. So that highly mobile appearance often is because of the jet that they're associated with. So that's why it's going to be kind of fluttering and moving around quite a bit. In the absence of mobility, another cause might be suggested. So if we don't see it mobile, it seems to be pretty rigid. It's more likely to be something like thrombus or a mass. Fungal vegetations relative to each other, to the bacterial ones, the fungal tend to be larger. Okay, so they can get pretty decent size. Tricuspid tends to be larger than mitral or aortic. So similar to the reasons that the flow differences are left to right heart, there's just a lot less pressure and less I don't know, less hemodynamic, significantly different flow states in the right side of the heart than there is the left. So therefore, they tend to be a little bit larger. And we'll talk about tricuspid and right sided heart stuff at the end of the slide set, but they typically are from people with drug use, so IV drug abuse. Large vegetations can also end up leading to stenosis if they stick around long enough to do that. Okay, so avoid any false positives. So our important thing is that we want to differentiate what's going on. So from other echo-producing abnormalities such as myxomas or myxomatous process, degenerative changes, and tumors and artifacts. So let's talk about myxomatous. What is myxomatous again? What does that mean?
Like a tumor or
So
cancer?
there's a myxoma, which is a tumor. But the myxomatous does not mean the same thing. Usually we'll describe a thickened valve as a myxomatous valve. So just a myxomatous valve, that terminology indicates that we have a thickened valve, which is usually like an aging process type of thing. What degenerative changes might show up as something coming from the tips of the valves and being highly mobile and moving around quite a bit? I'll give you a hint. There's one that was off of so just a regular degenerative change. We talked about it on the aortic valve, little filaments of stuff that kind of come back. It's usually actually on, it usually is coming back into the ventricle.
Lambeau's excrescence?
Yes. Yeah, so they're just little filamentous type of things. They shouldn't have any globs attached to them or anything like that, but vegetation typically will. So that's a degenerative type of change. And then obviously tumors and masses, we'll talk about that more later. The nice thing about the tumors on the valves is that they typically reside on the downstream side of the valve, usually. And then of course, any artifacts. So things like reverberations and things like that can mimic these types of things. So they can reduce in size due to healing or embolization. So if we see them one day and we follow them up the next day, if we're medicating them and treating them, that bacterial mass might start to constrict on itself and kind of just like a blood clot or a hematoma. If you got a bleed that goes out, eventually it's going to solidify. As it goes over time, it's going to get smaller and smaller and more compact and becomes more echogenic. So it can do that with treatment. We don't typically dissolve them. So it's not like we go in and give them a medication that makes it go away. But it's an inflammation type of a process, so it can be reduced if it's treated. Or the other problem is if it's suddenly smaller in size, then we're worried about it having broken off and embolized somewhere else. That's when we worry about strokes and TIAs and things like that. All right, clinical studies, only the sickest of the sick patients would be included due to other factors. So when they're doing clinical studies on these types of things, they're usually very sick patients. Just like when we started doing TAVR valves, those valve replacements of the aortic valve with the cath lab, they only could do those initially on very, very, very sick patients that didn't have any other options. Transthoracic approach is 60 to 70% sensitive to it. Obviously, transesophageal is going to be better. Fungal, sorry, I bumped that. So in most cases, they are interpreted in context, avoiding false positives. So while we're going through and thinking it might be vegetation, keeping in mind the other things that it could be and making sure that we're not misdiagnosing it. If we miss it on 2D, it's unlikely to be caught on 3D, so 3D won't necessarily help you, partly because you're not going to be looking for it. Inclusion of other factors over the years has brought specificity to about 99%, as reported in some cases with echo findings. So the location of it being on the upstream side of the valve, that lower echogenicity, that high mobility, stuff like that is suggesting strongly that it could be vegetation. And it sounds like we are getting better and better at that diagnosis. 99% is pretty darn good. But again, there's enough other features that could suggest that we miss it. So take home message, you have to have good echo evidence in B mode in particular. The jets and stuff help to suggest it, but it also goes in conjunction with your clinical history and blood tests and stuff to prove that that's what it is. So we are a significant part of the diagnosis, but not exclusively. Okay, so complications, obviously, so endocarditis, generally speaking, so it's an inflammation of the endocarditis. Vegetation that we've been talking about is specifically that, that globular mass type stuff that's on the end of the valve. That specific collection is called the vegetation. That process, remember, infective endocarditis, if we are inflaming a surface, what happens to that surface after the inflammation is gone? What do you think might happen to that?
Does it calcify?
It can. It could calcify.
Thinning, maybe?
Sorry, go ahead.
Was it thinning?
Okay, it may actually create holes. So we could develop a hole. We could get new shunts and stuff like that. If it's on the valve itself, it might create a perforation in the valve. So an infectious process of any kind weakens the tissue. When the tissue is weakened, it could become damaged and allow holes and stuff like that to develop, or it could develop scar tissue and become problematic that way. So it's not unlikely to be able to create things like regurgitations and that after the fact, after this vegetation thing is done and healed and gone. Those are just kind of residual effects. In the specific setting of active endocarditis, changes are sudden and can lead to dramatic changes in clinical status. So these patients are typically quite sick. They're not always going to be super sick, but they will typically be quite sick in an acute setting of it. Sort of like the idea of sepsis. You know, we always worry about an infection getting in, and then you get the sepsis where you get those little tracts of veins that you can start to see, you know, traveling up the body towards the heart. Obviously, when this infection gets to the heart and establishes on the heart itself, that's going to have dramatic changes. All right, so another complication of endocarditis. So we're leaving the topic of vegetations, and we talked a little bit about this before with abscesses. So an abscess is a local pocket of infection. So instead of something forming and hanging out into the blood, into the pool of blood in the chamber, it's instead going to be embedding itself into the tissue. So if anybody has had or knows somebody who's had an abscess, it's a pocket of infection. What happens with that infection? Where does it go? What happens to an abscess?
Well, if it's in your tooth, you need to get the tooth pulled because it starts going down to the tissues and necrosising.
Yes, so as you can imagine, it's still a bacterial type of growth or fungal type of growth. It's in the tissue now, so but they typically grow, and so that growth within a confined space, what happens with that?
Can it rupture?
It can rupture.
Oh.
Yes, so it can rupture. If something embeds into a tissue and ruptures, what does that now create for us in the heart?
Just a bigger infective process.
It could be a bigger infective process. It could rupture and create holes where holes aren't supposed to be. There's all kinds of things that can happen with an abscess. So it is a dangerous process. Remember that the reason it ruptures is because as it grows in a confined space, we increase the pressure. So think of like the pericardial, the tamponade situation. If we, in a confined space, if we too quickly increase the pressure inside of that, there's going to be problems. So it is a localized pocket of infection. And so just like tumors and masses, what do you think you want to do with an abscess from an echo perspective? You want to document it. So see it in every perspective that you can, measure it, ideally in 3 dimensions at least. And then because we're close to the blood, and if it does rupture, we want to see if there's a connection to other areas. So we put color Doppler on, and we're going to see if there's any kind of flow going into it or all the way through it into the other chamber that it's adjacent to. So, so we'll measure it, we'll put color on it and stuff like that. You're not necessarily going to spectral Doppler it unless there's a complete connection going across from one chamber to another, then you will. We're going to look for echo dense or echolucent masses with tissue. What does echolucent mean? Is that a term we usually use to describe our intensities of signals?
Maybe transparent.
Yeah, so echolucent meaning like anechoic. That would be type of thing that you're looking at. So it's a hypoechoic to anechoic type. So just know that echolucent just means that there's no echoes in that space. All right. So most often it's going to occur near the annulus of the aortic or mitral valve, which can obviously affect the function of those valves. It can also affect the conducting system of the heart. So you might have some EKG stuff that occurs because of that. It can spread to adjacent structures. So as we know with abscesses, they grow within their space, but they may infiltrate on the space of other structures. They could rupture, causing communications, as we've already suggested. So color flow is going to demonstrate flow within the abscess cavity. So regardless of if you think it is ruptured or not, it's appropriate to put color Doppler on it to see if there's flow and swirling and stuff going on in the inside of that. If you obviously see color Doppler, then that is problematic. Now, in addition to that, let me go to the next level of that. So if I've got a rupture, what is that? What was inside that abscess?
Infection or bacteria?
Yeah, nasty stuff, right? Where does that go if it ruptures?
Everywhere.
Everywhere. That's not stuff you want floating around the body too much. So yeah, just keep that in mind too. So you might have, like I said, these are going to be patients that are very, very sick typically. Color demonstrates flow within the abscess cavity. Bedside conduction abnormalities may be a clue as well. So we might see EKG abnormalities, and then we use echo to be able to get a visualization of what's going on. We talked about valve replacement. So the fact that we do a valve replacement, what do you think that would, does that make you more likely or less likely than a native heart to have heart valves to have abscesses?
More likely.
Yeah, we're going in with man-made stuff. We've now exposed the inside of the body to things from the outside of the body. Potentially speaking, even though we're good at sanitizing, typically stuff can get contaminated and get in there. And that can, at the very least is going to have an irritant area that will possibly seed an infection that can start that. So do you remember what we talked about? What was the terminology we talked about around the outside of the valve that we were worried about after a valve replacement?
Regurgitation.
Okay, so we see regurgitation, and there's a particular type of motion that valve replacement has. What was that called?
Rocking.
Rocking.
It was the rocking, and what was the other term we associate that with? When it detaches.
Disheavance.
Dehiscence.
Dehiscence.
Good, exactly. So that's one of the things that can cause dehiscence is these abscesses that develop behind those valve structures. Okay, and any real question about stuff going on from an echocardiographic standpoint, they're going to definitely want to do a transesophageal to get a better look at it. Okay. So other things, then we have areas of thickening, either echo dense or echo lucent areas are suspicious again. Mycotic aneurysms of the heart involve the aortic root, similar to an abscess. What does mycotic mean?
It means an infection caused by a fungus.
Yes, exactly. So they can also involve the aortic root and continue up. So we want to also look for if we've got concerns of endocarditis and stuff. Remember, it's not just the heart that has the endocardial type of lining. So the vasculature also has the endothelial type of lining, which is a similar process. So they can spread up the vasculature also, causing weakening and therefore causing aneurysmal formations and stuff as well. In that case, we're looking for echolucent outpouching of the vessel wall. You're familiar pretty much with what an aneurysm is, and of course, we'll cover that more even next lecture. It's connected through a single channel with within the vessel. So again, we're looking for channels or openings or windows between not only cardiac structures, but we're also going to be looking for connections possibly between like the aorta and pulmonary arteries and stuff like that as well. Just remember that the abscesses can have infectious material, or they can contain the free-flowing blood, and then a rupture of that can produce a shunt all the way across both of those chambers. Okay, so purulent pericarditis. So infection may spread to the pericardial space, as we've just talked about. So that's what we call the purulent pericarditis. What does purulent pericarditis mean? So what's an abscess? What's in an abscess?
Pus. So purulent means it's filled with pus.
Yes. So it's a pus-filled pericardial space. So if you're looking at pericarditis, and you're looking at collection in that space, what do you think pus would look like on an echo? Would it be anechoic and clear? Would it be something else? It's gonna look kind of gunky, right? It's gonna look like there's echogenicity and stuff within it. It may still be moving, but remember, what is pus actually formed with? It has bacteria and stuff, but what else is in pus?
White blood cells, dead ones.
Yes. So remember, any of these infectious processes are going to have white blood cell involvement as well that migrate to those areas. So clinical evidence of pericarditis in an acutely ill patient, coupled with echocardiographic evidence of the pericardial effusion, should suggest the possibility of this purulent pericarditis. So again, you're taking your clinical history and combining it with what's going on when you're seeing those pericardial effusions. And this is typically a surgical emergency. We established that on clinical grounds, being the overall, what's happening with the patient. There's signs and symptoms and other tests that they might have. The most devastating effect of these is also an embolic event, which would cause possibly a stroke. Echo can also be used to show a reduction in this process as well. So we may follow the patient after treatment to see if it's if the space and stuff is improving. Okay, so the prognosis and predicting the risk of this for the patient or of bad outcomes. So 40% of patients have been treated for active endocarditis develop complications. Risk factors are going to include things like age, the type of organism that it is, so between fungus or bacteria, or even specifically the types of fungus or types of bacteria that are involved, and the development of heart failure. So if it's gotten to the point that it's affecting the function of the heart, that's going to lower our outcomes of success. Vegetation size is the only echocardiographic feature that's consistently associated with increased risk. So in other words, the bigger it is, the bigger the risk is from an echo perspective. Increase in size after 4 weeks of antibiotic therapy should prompt consideration for surgical interventions. In other words, our antibiotics aren't doing what they need to do, and it's still growing out of control. That's problematic. Okay, the location as well. So one study showed that mitral valve involvement was 3 times more likely to develop an embolic complication compared to the aortic. So just from a statistics standpoint, you want to pay good attention to which valve it's on. Mitral valve is also more likely to be larger, which may contribute to that same likelihood. In short, risk assessment will include clinical, bacteriologic, and echocardiographic used in combination. So again, we're doing the echo in conjunction with a blood test to prove what specific type of bacteria or fungus it is. How will, just putting it out there, how will the outcome be affected if you just assume it's a bacterial infection? Can you give the same medication to treat? No. There's antibiotics are typically affect bacteria, so they will affect bacteria fairly universally, but there's certain types of bacteria that they work better with than others. There's other antibiotics that work better for other types of bacteria. But there's also antifungal medications as well. So for example, I don't take penicillin, for example, to get rid of fungus that goes on your foot, like athlete's foot. It's a specific type of medication that's geared towards killing off the fungus. So there are different types of medications, which is why it's important for them to do the test to determine what exactly is causing the problem. Because if we treat with the wrong medication, it's not going to do anything to it, and it's going to continue to grow and get worse. Okay, so vegetations often occur at the base of the sewing ring of the structure when it's a valve replacement or some type of implanted device, okay, on the prosthetics. The other issue that we have to look at on the prosthetics and stuff like that is that we can't see around it completely as we would a native valve because of all the shadowing and stuff coming from the sewing rings and things like that. So remember, on any prosthetic valve structure, especially if we're looking for impingement of the leaflets and stuff like that, we're looking for thrombus, we're looking for pannus formation, but we're also looking for things like vegetation. And they're not going to form on the tips of the leaflets like they do with the native valves. So we need to look around the valve very carefully. And if there's a strong suspicion of it, they're going to probably do a transesophageal also to be able to get around, particularly the mitral valve. So just again, suggesting to use any other additional windows for diagnosing it and seeing it more completely. Transthoracic is not adequate to exclude endocarditis in patients that you suspect it might be there. So again, if we have a strong suspicion, but our transthoracic didn't show anything, any evidence of it, you definitely want to be using a transesophageal as well. But keeping in mind that the TEE also has artifact that's just coming from an opposite perspective, being from the back of the heart. So really a combination of the two would be best. All right, so infected intracardiac devices. So soon after implantation of these devices, it could be caused from the procedure itself. So we may be introducing bacteria. Maybe one of those devices got contaminated before they put it in. That can cause that to occur. Or a pre-existing infection when they did it, and maybe they didn't have them on antibiotics or something like that, or the appropriate kind of antibiotics. Late ones, so this is quite a while after the surgery is done. That's usually used from seeding the bloodborne organisms into that space, just like a native valve situation would be. It's difficult to treat without removal and are associated with a very poor diagnosis. So obviously, we don't want our patients with transplants to be getting these. That decreases their chance of success pretty dramatically. Again, it will be detected with transesophageal in most cases. And then distinguishing a vegetation from a thrombus is going to be done again via the clinical info, the recent infections, fevers, stuff like that that the patient presents with, and blood tests in addition. And then, as I alluded to earlier, right-sided endocarditis is most commonly associated with IV drug use or indwelling catheters in the right ventricle. So IV drug use is pretty obvious, particularly people that reuse needles, get the dirty needles and stuff like that. Obviously, we're much more likely to do that. I haven't been around a lot of IV drug users, but I'm assuming they don't use alcohol swabs and they don't have a nice sterile technique when they're implanting these things into their arms or legs or wherever they put them. But why do you think it affects the right heart and not the left on IV drug use?
Venous system.
Yep, it's a venous system, and all the venous system goes back to the heart on the right side of the heart. So that's why. And what about indwelling catheters and stuff in the right ventricle? Why do you think that is a risk? So an indwelling catheter is a catheter that goes into typically an arm vein and then goes up into the heart. That could be, with temporary pacing wires, but it could be often used for people like on cancer therapies and stuff like that. Nancy, go ahead.
It's a foreign body for stuff to attach to.
Yep. Yes, foreign body, absolutely. So particularly the ones that actually come out the arm and are temporarily there, but they're still attached to the arm, allowing a surface from the outside towards the inside, a connection. Now, a pacemaker is going to have less, an implanted pacemaker is going to be surgically actually implanted under the skin. That's going to be less likely, but not impossible to cause that. And again, if it's because it's recently implanted, maybe there's an infection that got seated in there, or just the fact that we have a structure there that allows a normal infection to have a place to seat itself. And again, as alluded to earlier, the right side of the heart typically has larger development of endocarditis than the left side of the heart does. And sort of like we did with the serotonins and stuff like that, we may get irritation going to the left side if there's also a shunt, like an ASD or a PFO or something like that. TEE superiority is less well established on the right side. So thinking about a transesophageal, why do you think it would be less diagnostic than a transthoracic might be compared to the left?
It's more anterior than where the transducer will be.
Yeah, so it's deeper to the transducer than our transducer is. So that's correct. So it's got other stuff in between it. It's very good at left-hearted stuff, left-sided heart stuff, because it's right adjacent to it. And it's a higher frequency, so the penetration is going to be a little bit more poor seeing stuff on the right side than our transthoracic would be, which is quite a low frequency. Masses often remain after treatment, therefore differentiation with active and healed can be difficult. So typically that's going to come to a patient that has is less symptomatic and stuff at that time. Maybe they don't have the high-grade fever at that moment. And documentation of them having had it is important. But are all patients that come in with vegetations, are they all going to always be seen in a hospital, or do some patients get by and maybe have a vegetation formation, but on their own they just kind of recovered from it, and maybe you don't know about it? Okay, so there are chances that they may have had it in the past, and again, that clinical history is important. How many IV drug users do you think are going to tell you that yes, they're an IV drug user? Probably not a lot, right? So that's where you may, not that we're looking for signs of things, but if you're seeing like those classic track marks of scarring and bruising and stuff around the veins, all up the arms, that's going to be clues that something's going on, even though that patient will never tell you that. Okay. So an interesting thing, my mom used to work in as a booking clerk and a transcriptionist in the X-ray department back in Canada where I grew up. And she sent me a picture of this guy's x-rays one time. He was supposed to get an MRI, so kind of flashback to our MRI section in 136. They had to determine, because he was an IV drug user, and so they had to determine if there's any metals and stuff in his body that would be affected by the MRI. So they did an X-ray of each of his arms. No joke, and I don't even know if I have the picture anymore, but it was amazing. It was obviously de-identified, but she showed me the pictures of those, and there had to be at least 100 needle tips in each arm under the skin from IV drug use. Okay, where they stick them in the arm and then they break off inside the arm. So this guy had hundreds of tips in his body. So they obviously couldn't do the MRI, but it was crazy. And that is endocarditis and infective endocarditis. Any questions about that? So are you typically going to see endocarditis, or would you see it, do you think, very often in a clinic setting or a hospital setting? So
Hospital.
definitely more in a hospital. So these types of things you're a lot less likely to see out in a clinic. Does it mean you won't see them? No, you can still see them. Maybe you're the one following up on that patient after they've been treated and stuff like that, but you're not going to see typically the acute phase of that because they will typically be hospitalized. And keeping in mind too that somebody with severe symptoms may not even be able to communicate with you at all because they might be unconscious in an ICU or CCU. Okay, so you're going to have to look for signs and symptoms and maybe gather some information from wherever you can. Maybe it's a family member that's there with them. Maybe it's the nurse that's taking care of that patient. It is appropriate for them to talk about those things. That is not a HIPAA violation because it is directly relevant to our exam. And you are part of the clinical process of that patient. So that is not a HIPAA violation. All right. Kind of a fun and interesting topic.
Can I ask a question on the blood flow with the abscesses?
Yeah, go ahead.
So you were saying, I remember you saying at one point that that was like a defining factor for tumors and masses, was being able to have a blood supply to it. Is it going to be much different from the abscess? Will there just be blood flow but no blood supply?
Yeah, it should not have a blood supply. That's correct. So, and when we talk about the masses and tumors of the heart, some of the ones like embedded in the walls and stuff may have a good blood supply, but ones hanging off the valve, while they do have their own blood supply, how easy do you think it will be to see those with?
Probably very hard.
Yeah, simply because we have a lot of movement inherently with the blood flow and the hemodynamics that's normal around it. So if it was still and it was just sitting in a liver, for example, we could probably see that blood flow within it. But with echo, because there's so much movement, we simply won't be able to.
Okay.
Now, if it's something coming into like the right atrium that looks like a thrombus, that's not moving very much, so that one we might be able to. But if it's on a fast-moving part of the heart, it's unlikely we would see it, even though we could theoretically see it. But that is a good point. Tumors and masses definitely have their own blood supply, where these will not have their own blood supply. It's just an inflammation and swelling process.
Okay. Thank you.
Yeah, and abscesses, what we're concerned about abscesses is the blood connecting into it. It's going to be washing out that space. So it's going to be coming in and going out of that space and or going completely across that wall into the other structure adjacent to it, like the right heart or the pulmonary artery or something like that.
Okay.
Fun stuff. So this is kind of an emergent thing in the sense that they got to get taken care of right away, but it's not like a tamponade type of emergent situation where I got to get a quick couple of pictures and go show the doctor immediately. It's an acute process, but it's not imminently dangerous. But you don't want to send them home. And so this would be an example if you saw a patient like this that was pretty sick and they did walk into the clinic, for example. Say you're at a clinic, because this can happen. You're at a clinic on your own where there's not a doctor on site, and the doctor reads that study, every couple of, within 48 hours or maybe a week, because that does happen in some of these rural sites. Even rural hospitals have cases like that. do you think it would be appropriate to just send the patient away and just let the process take place, or what do you think you should do on that situation? It's not imminent danger, but what should we do?
Probably give a wet read.
Yep. So it's very appropriate to call the interpreting physician, the cardiologist, or whoever it may be, and let them know. Now, it's not appropriate for us to call the ER. It's like, oh, I think they got a vegetation. That's not our job, and you have to have good proof for it. But it is appropriate to contact your cardiologist, whoever's reading that study, and get it escalated. So, for example, at Inland Imaging, we have our routine read, which means that it has to be read within 48 hours. Then we have our urgent reads, which means that it has to be interpreted within 2 hours. And then we have our stat reads that have to be interpreted either within 20 minutes or 30 minutes. Okay. So at very minimum, you want to escalate the importance of that study, because that will determine how quickly that gets read, because this is not something that should be let go for a long time. Is it absolutely emergent? No, but before I let the patient go, I would absolutely be on the phone with my provider and see let them know what's going on, and make sure that your clinical report is written up and that it's all ready to go, and so that they have it. So as soon as they look at it, they've got a complete case and they can do a quick interpretation, and they will make usually a phone call to to that patient's provider. So anything urgent like that is totally appropriate to contact your cardiologist and let them know what's going on, even though it came in as a routine study. But you definitely don't want these types of things to be let go too long, because they can change rapidly, especially if they got purulent pericarditis. Makes sense. Since we're on that note, because we haven't really talked about the urgency and the status of these types of things, what other things do you think would be appropriate to call your doctor about, your cardiologist, before you let a patient go?
Are we going back to pericardial disease?
We'll go to everything at this point, everything that we know about the heart.
Tamponade for sure.
A
Absolutely.
ruptured septum.
Okay, yeah, ruptured septum. Yeah.
Moderate to large effusion, or even, I guess, pleural too would be involved with that.
Okay, good. Pleural is usually a little bit less concerning if it's just pleural effusion, but pericardial effusion for sure, I'd at least be bumping it up to an urgent and probably talking to them about it.
Maybe anything
Aneurysms?
acute.
Aneurysms, yeah, and somebody else is saying something too.
Anything acute.
Anything acute, yes. Yeah, Nancy?
Yeah, AFib and thrombus.
Okay. Thrombus, absolutely. AFib, honestly, AFib is one of those that's fairly common. Now, if it's a long-standing AFib that's been going on for a long time, then yes. If it's intermittent AFib, it's really honestly not super concerning.
I just meant combined with thrombus.
Oh yeah, definitely.
Like ruptured chordae or
Yes.
papillary
Ruptured
muscle.
chordae tendinase, so acute changes to any valvular regurgitation and structure, definitely. What about
Dissection. Heart attack.
dissection? Yes. Heart attack? Yes. Yeah. So these are all things that you should absolutely, whether you're scared of your doctor or not, you need to let them know those things right away. They'll actually get a lot of respect for you when you keep them in the loop on those types of things. And sometimes it's safe to, if in doubt, you should talk to them. We'll say it that way. Because they can always tell you, no, don't worry about that. They might explain the situation to you, and you can see by their calmness that they're not super concerned about it. But you definitely don't want to let something slide because you're afraid to talk to your doctor about it. Definitely let them know. And if you're coming to them all the time about little things, they're going to probably help guide you as to when to and when not to discuss those things with them, because they are busy. They have a lot to do, but we definitely don't want to let the important things slide by. Good.
Scott, I
Hey,
have a
Scott.
question.
Yeah, Irina, go ahead first, and then after that.
Thank you. So what do we need to say something to the patient if you have some acute situation like
Nope.
we discussed now?
No,
What we
I
need
would-
to say
I
to
would
patient
talk-
exactly? Like
I would talk to the doctor first. So if there's something going on, what I would do, if it's a really emergent thing, I would do one of a couple things. So if it was something like tamponade, I may not leave the patient alone, but I may have somebody else get the doctor and let them know what's going on, or have somebody else come in the room and watch the patient while I go get the doctor or talk to the doctor, because you don't want to leave those patients alone. Otherwise, just tell the patients, like, I just need to check some pictures or talk to the doctor for a minute, and just do it professionally, do it casually. Don't have panic in your voice. Don't be like, I got to go check with the doctor. I'll be right back. That's never good. Patients are going to freak out. We don't need to have that. So just calmly state that you need to get out of the room, to go check on something, go talk to the doctor before you let the patient go. That's totally appropriate. If you think the patient is unsafe, then either you need to stay with the patient, or somebody needs to be watching the patient while you go talk to the doctor, or they talk to the doctor. That's important. But typically on a patient, you're not going to tell them what's going on. That's completely up to the cardiologist to do, because we don't pay medical malpractice insurance typically, and we don't have the diagnostic expertise to actually to give them that information. And we're giving what we suggest is proof towards those things, but we're not always right. And remember that the doctor has the complete story of what's going on with that patient. They have more comprehensive knowledge about that, so we'll leave that to them. So you do have to play the poker face a little bit. Again, good rule of thumb is if you feel like your patient is unsafe, make sure they are safe while you make that communication happen. Typically, we're not going to if we're concerned about it, we're not going to usually let the patient go until the doctor gives us clearance to do so. And sometimes it's even appropriate just to have your patient get changed and wait in the waiting room and not leave until we let them know that they can go. And then, if it's depending on the urgency of it, the cardiologist may take them aside and talk to them individually, or they might give them, and you might have to give instructions to the patient from the cardiologist and say, you know what, your doctor's going to call you and you're going to talk about what's going on, and they may stay there at the clinic to do that. They may do something else. Sometimes they have to go to surgeries and stuff like that. So you can be an in-between person, but the one that makes the decision is definitely the cardiologist and not us. And we don't tell them any information specifically unless we're told to do so. And then when you do that, all labs are a little bit different on this, but at Inland, our policy is when we tell a patient something, like doing a DVT study, for example, if we find a positive for blood clot, we are sometimes asked to call the provider ourselves and tell them what's going on and tell them that it's positive. But if you do that, I would always document on your report that you spoke to, a certain doctor or nurse or provider. You list their name and their credentials and the time you talked to them and exactly what you told them. That way we've documented our part of it. So if it ever comes back to us, we can say, hey, it's written right here. This is exactly what I said and did. So that's how I would handle it. You want to cover yourself.
Thank you.
Yep. Does that answer your question?
Yes, thank you.
Somebody else had a comment too. I didn't see who that was.
Oh, you answered it with your
Okay.
that last part.
Good. Yeah, there's still a lot to learn. I mean, we're gonna get through this quarter. We're gonna know most of the stuff about the echo itself and the heart. But then there's the whole clinical side of things and what's appropriate to do and say and how to handle this and handle that. The summer course, Tyler should talk to you somewhat about in the 142 lecture component. Talk about taking patient histories and just how to interact with patients properly, all those types of things. And then even when you're in clinic, you're still going to learn stuff that you haven't heard of. And that's how we learn. Just remember, when you graduate, you're still going to probably be about 2 to 5 years before you really feel comfortable doing echo. Okay, and then that's kind of the peak of most people's careers, between 5 and 7 years, unless you're really aggressive at it. All right. Infective endocarditis.
Before we leave, I kind of wanted to ask you about the schedule. So if we did the diseases of the aorta tomorrow, would we not have lecture on the 1st?
So if we did the diseases of the aorta tomorrow, let me bring my schedule back up here real quick.
I think even if we did the disease of the aorta on Thursday, we probably still wouldn't have lecture on the 1st.
Right. Yeah, that was my other question, because even if we did it on
Mhm.
Thursday, if we only have one lecture left for mass and tumor,
Right.
not quizzes on the 3rd.
Yeah, either way, I mean, I'm fine to do it whatever way we see fit, but if we do diseases of the aorta tomorrow, we don't need to have a lecture on Thursday. Now, another option is, I'm not sure you're gonna want to take this option, but we could actually do diseases of the aorta tomorrow, and we could do masses and tumors on Thursday. And then still leave the quiz time, leave the quiz times open, but that wouldn't necessarily give you a chance to read through the material. Nancy?
What if we did the diseases of the aorta on Thursday and masses and tumors on Tuesday? That still gives us 2 days in between quizzes, maybe.
It does.
I like that idea.
So I do want it to be unanimous, ideally. Otherwise, we pretty much just leave it the same as it is. But what about tomorrow, since we have presentation tomorrow? I guess our main ones, is it Hannah and Graham? Is that the two of you that are doing it tomorrow?
Yeah, and both of us, I think, would prefer to just keep it at the same time.
Okay, so keep the presentation at the same time?
Yeah.
Okay. Do you guys have a preference whether we lecture tomorrow or not with the aorta?
I think we can hold a quick poll in Discord. Aorta on Thursday. Upvote that if you want that. Aorta Wednesday, tomorrow. Upvote that. If you want masses on Tuesday, upvote that. If you want masses on Wednesday, upvote that. Or some other combination, somebody want to type and do a different combo?
So let me test this, Nancy, since you're talking about the polls, because apparently Zoom has polls.
Oh.
Let me try it here first. So I'm going to say, do you want to?
Can you put in a no preference on there too?
Yes.
I just want to try this poll thing out. Let's see. I'm just going to do yes and no. Do you want to do this lecture tomorrow? Let's try that.
So Scott, regardless of what we do, would our last lecture be on the 1st or the 2nd? Because if we were sticking with the normal schedule, we were doing the aorta on Thursday, and then what we were going to do Tuesday masses, or was it what's supposed to be the 2nd we were going to lecture?
So let me bring this up again.
That makes sense.
So I think, so what I'm mostly concerned about today is, do we have a lecture tomorrow or not? Because I was thinking I would leave the quizzes on the same day to give you time to go through those.
Yeah.
Let's see. I'm launching the polling there, by the way, so if you want to take a look at that while we're talking. That's kind of my main thought. We can leave the schedule totally as is. So if we did that, we would lecture on diseases of the aorta on Thursday, and then lecture on the 2nd, which is Tuesday, the masses and tumors. Regardless, the quiz for endocarditis, infective endocarditis, will be open on Thursday. The one for diseases of the aorta would be open on the 2nd, and the one for masses and tumors is open on the 3rd.
Tuesday is actually the 1st.
Yes. Sorry, yeah. So Wednesday, masses and tumors is Wednesday the 2nd, as would be the quiz for aorta.
Oh, so you're saying the tumors and masses quiz is set for the 2nd? I had it down as the 3rd.
I have it as the 2nd.
Masses and tumors is on the 3rd, the quiz.
Wait.
Okay.
The lecture will be on.
Okay.
Okay.
Let me verify my, because I did correct that on Canvas. Let me check that.
Just clarifying. So if we do move the lecture earlier, are we going to have more time for the final to cover that?
If we bump everything up, that would buy us more time to discuss, to review final.
By everything, do you mean even the quizzes or just the lectures?
Well, the quiz, we could still discuss the, we can't discuss any specific quiz questions before the quizzes are done, but we can still discuss the general content of those.
Okay.
Right now, does the
Or I can
schedule
review
show that we're
if you wanna
reviewing
move it up
2
to-
days? Oh, sorry to interrupt, Scott.
Sorry, yeah, I mean, I could do any of the above as far as changing it around. I just want to have us unanimous on it, which it looks like it is not unanimous actually even for tomorrow. So let's see. And,
So
yeah,
in regards to the reviewing for the final, my calendar shows us that we're able to review the 8th and 9th with the final on the 10th.
correct. Yes.
That's 4 hours of review. Do we need another class period to review? Actually, even if we're not lecturing on Thursday, the 3rd, so no matter what, we could review that day anyway. So that's 6 hours of review.
Yeah, we could do the 3rd as well. Yeah, we should have lots of time to review. But we will still hold the final exam on the 10th. So it looks like the polling's coming out at least split. It's not unanimous, but so we'll just not have class tomorrow. So we'll not have class tomorrow for the lecture, but we will do the presentation tomorrow. So that will be at 11:30. And so just join in. I'm going to join in on the 136 class on the calendar for that, unless you prefer to do it with the 253 Zoom link. Kelsey?
When's our portfolio due again?
By the end of the quarter. If you've got, so I grade these individually per section. So I want to see each of them. And so you'll get a grade for each of the sections. So bring those to me as you can. And we'll kind of go through those as long as I can see them before the end, before I submit grades. Having said that, I do like you to be able to have them for studying.
So a lot of us weren't able to jump on the practical for vascular as quickly, and they filled up just really fast. Are there going to be any other opportunities for extra credit?
It seems that they did theirs early. I wonder if that was for the second years. They might have more options through vascular. I'm not sure what Rachel has planned. So there might be more opportunities there. I don't have any imminent stuff. So generally I give my extra credit for things that promote echo specifically, and or the allied health stuff. So anything that you do that contributes to that, as long as I get a note from somebody indicating that you're there, some proof of it. We did blood donations last time. We could do that again. Anything that promotes, our health field would be appropriate. And I'd be willing to take whatever, as long as it's some type of thing giving back to the community in some way.
So Scott, if we've
Thank you.
already volunteered with the vascular and then we went and did blood donation, would that be a second extra credit?
Yes, correct.
Thank you.
Yeah, and if you haven't got me, so if you did sign up for Rachel's stuff and she didn't give you a slip, just ask her for a slip, one of those extra credit slips, just so I've got a documentation. I think I've only got one person's. Yeah.
I think she said she's gonna send you some email or something, the list of people who participate.
Okay.
That's what she told me
Say that a
too.
while
Yeah.
ago.
Say it again, Scott.
Did she
please.
say that? Was that a while ago that she told you that?
It was the day when I was volunteering for vascular. So I asked her, would you give me some paper or something? And she said, no, I'll let Scott know who will participate.
Okay. Not here.
Just to clarify, the portfolio is considered extra credit, right?
No, portfolio has its own grade.
Oh, okay, got it.
Okay, so I'm looking at a thing that she sent me for volunteers for that, but all I have is the people that need it. It doesn't have a list of people that did it.
Scott, I have an email from Rachel that she sent out clarifying who were volunteers, and it's a list. I can forward that to you.
Yeah, forward that to me because I don't have anything from her indicating who showed up and who participated.
One other question about registration. Do you want us to register for fall now also?
Yeah, you can register for fall. Let me take a quick look at fall schedule. So fall schedule though, we have the clinic and the lab. The clinical and the lab are split. So let me just look at the schedule here.
Yeah, I saw there's 2 different dates for the clinical for fall and I wasn't sure there.
Yeah, usually I kind of split it up, but basically it's not going to matter who goes into what section, except let me talk to Tyler about that first, because what I usually do is those that go to clinical locally here first will go back to clinical starting at the beginning of the fall quarter. So they're in one section and the lab will be in the other section. And I like to keep it that way because when he has each group there, if we do it just randomly, we're not going to have the right sets of students in the lab for grading purposes. Clinic's not going to matter as much, but unless he combines them. So let me talk to Tyler first on that before we do that.
Okay, thanks.
Yeah.
So Scott, just to clarify, I'm sorry, I'm asking this again, but are we lecturing on Tuesday or no?
We will not lecture tomorrow.
No, on Tuesday, the 1st.
I think we'll just keep it as it's normally scheduled. So we'll be lecturing on the 2nd, and the 2nd.
Yeah, because the next quiz is on, well, for that section is on the 2nd, and then we're just going to lecture over aorta on the 2nd, quiz on the 3rd.
So so the diseases of the aorta will do this Thursday, and then masses and tumors will do on the 2nd, and then the quizzes will be as they're scheduled.
Right, so no lecture on Tuesday.
No lecture on Tuesday, correct?
Okay.
Yeah, so we'll just keep it
I
as.
want to be able to plan my time accordingly.
Yeah, we'll just keep the schedule as it is. That's the fairest way to do it. Okay, so did I answer all of our questions? Did I get lost?
Scott, I have one more question very quick. So is it like necessary, how to ask it? Is it possible to do quiz not till the beginning of our lecture, but till the 12 o'clock like it's in a schedule? because sometimes it's kind of hard to do it before even Darren's lecture on Tuesday and to be able to jump on in our lecture on echo. So
I think I didn't change any of the times as far as how long it was open. I never did change that. I just left it as it was.
okay, so from till the 12 o'clock, right? Like it's scheduled usually.
Let me verify real quick. So yeah, they're still open till 12 noon, yes.
Okay, thank you.
Did everybody take the quiz?
Yes.
Yeah.
Yeah.
Did we already review it then?
We did not review it for pericardial disease.
Yeah.
Let me check this. There's still one that hasn't taken it, so we can't discuss it yet. Yeah, I can see if everybody's taken it. It's still not complete yet, so we won't be able to discuss it quite yet.
No worries. That's okay.
Yep. There's a few 10 out of 10s, so I hope there's not any egregious ones.
No, I'm learning how to look for your little words on true and false. I'm finally learning.
Good.
It's taken me too long.
That's a good thing because I'm not the only one that does that. Good. All right, so it sounds like we are talked out. Any other questions? I'd say have a great sunny day, but it's not so sunny out there, but maybe we'll get some more rain for our plants. All right.
Thank you.
Thanks, Scott.
Have a good one.
Thank you.